Thank you very much, Lara. It's a pleasure to be here to introduce the first session. My name is Dr. Alan Hakim, and I'm the Chief Medical and Scientific Officer for the Ehlers-Danlos Society. And before I start the session, I'd just like to take the opportunity to really thank the facilitators, the panelists, and the workshop colleagues who've worked really hard over the last few months to make this happen. So can we maybe just give them a first round of applause for all of that work? Okay, we're going to start off today by just exploring some of the more general areas of the complications of EDS and HSD. I'm going to start with a very short, kind of principled conversation rather than go into anything in any detail. And then we've chosen a few of the particular topics. There's an echo coming through here. I don't know if we can do anything about it. That's much better, thank you. Okay, let's crack straight on. So, these are my affiliations. I won't read them all out to you, but it explains why I'm so fatigued. I try and keep a happy face. If I start to look grumpy, just come and give me a cuddle. I'm very up for that. Okay, so I'm going to look at this from the context of, or the concept really, of there being both the primary diagnosis concerns that we have to understand to make an initial diagnosis of Ehlers-Danlos syndrome or hypermobility spectrum disorder, and then the other complications, which we currently title the co-morbidities, which are the multitude of other complex issues that aren't actually in the diagnostic criteria at the moment. And I say that at the moment because there's ongoing work to explore all of this. But I think it's helpful for us to think about these two together in tandem, and I'll explain that in a moment. We'll then look at some of the learning when we look a little bit further afield from our own discipline into areas like long COVID and fibromyalgia and ME, CFS, and even into some of the other sciences, including some of the oncological sciences and the immunological sciences, where we're beginning to see lots of insights that mirror what we experience in the research that we're doing in EDS and HSD. I'll share with you some common sources of information and also just a few introductory thoughts about the core team and multidisciplinary working. It's really setting the scene both for today's panel conversation and then the rest of the meeting. The panel, my illustrious panel, thank you so much for coming. They've all promised to clap and smile all at the right moments and not boo me or say anything that along the lines of, I think Fraser said that's rubbish. He didn't know I was going to pick him out. But we're going to be talking about cardiovascular autonomic concerns. We're going to look through some gastrointestinal complications, thinking about it from a nutritional perspective as well as a GI clinician perspective, some of the neurological complications and then some of the skin complications. And then after the panel has had their session, we'll then have a full audience Q&A. Okay. So this is the slide that I want to put up that really reflects the conversation about understanding the primary diagnosis of Ehlers-Danlos syndrome. So we're not talking about all of the comorbidities that makes up so much of the challenge of our health status, but the actual issues that make up the primary diagnosis. And this is where we're looking for those red flags that might suggest that there's some form of rarer type or monogenic type of EDS. And this is a really lovely diagram that was published back in 2020 in a paper that Francisca Malfay and colleagues put together. And essentially, you can just see by eyeballing it that it starts at the top and it finishes at the feet, or it starts at the feet and it finishes at the head. And every single system is involved. And so as clinicians, we would naturally expect a multidisciplinary approach to this because no one clinician can really handle all of this in one go. And when I say clinician, I mean across the whole spectrum of healthcare professionals, so allied health professionals as well. So ocular disease, dental disease, oral disease, gastrointestinal disease through the entire tract, pulmonary disease, cardiovascular disease, skin pathology, musculoskeletal pathology, bladder pathology, you name it, it's all there, and these are all direct complications that we recognize in part in different aspects of the different diagnostic types within EDS. And today we're going to focus a little bit more on the gastrointestinal and on the skin as part of our discussion. But you'll note there that there really isn't any conversation about the neurological manifestations. There's no conversation there around the autonomic manifestations. These are all other areas that we're learning an awful lot more about and becoming much more familiar with, and we will focus on those a little bit more in the panel. And this is where I kind of flag all of the various concerns that people raise within the kind of conversation around the comorbidities, the common allied associated problems. So that list that you saw on that first diagram really sort of describes that plethora of organ-specific pathologies that you see as a consequence of EDS. But we now recognize that there are a number of different neurological manifestations. And I would just flag to you a beautiful volume from Frontiers in Neurology that was published last year. It was under the auspices of Eileen Aruhoy as the lead guest editor. And I think several people on the panel may well have actually got papers in that volume. There are 16 papers in there, and they talk in depth about the complexity of the different neurological manifestations in EDS. And so it's not a topic that obviously comes to people's minds. If you ask a general doctor in the street, what is EDS, you're more likely to get, I don't know. But if they do know, they'll probably say it's something about joints and it's something about skin. Well, it's an awful lot about neurology too. So there's all this learning that's coming, and we'll talk a little bit about some of that today. Many of you will be familiar with the concern that we have seen of mast cell activation disorders as part of an inflammatory pathology that's going on for a number of individuals. Well, we're going further than that now in terms of understanding the science and beginning to see that there's much more auto-inflammation, much more autoimmune pathology that's starting to manifest itself. So watch this space, but it's an area that's really coming to the fore. And I think more so because of our learning of the experience that people have had with COVID infection and COVID vaccination. When you do something like this to a mass population, you start to see the reality of what the environment can do to trigger inflammatory responses and start to drive things like mast cell activation disorder. We will talk a lot during the course of the sessions around psychological health, and it's an absolute imperative that it's run in parallel with physical health in terms of understanding overall health status and well-being. And we have a session on neurodivergence, which I think is tomorrow. Today we're going to be talking about autonomic dysfunction, both in terms of cardiovascular autonomic dysfunction, but also its relationship with the gut. And then, if it wasn't enough, chronic fatigue, I haven't even mentioned pain, which is universal. Chronic fatigue is such a common and, quite frankly, exhaustive problem, both for our patients and for us as clinicians, because it's so challenging. And it can manifest in its own right, but it's also very clearly driven by all the things that I've got on that slide. So when we spend time thinking about chronic fatigue and chronic fatigue management, it has to encompass the thought about all of these different issues. Now, either you are a fantastic physician, like me, didn't I say you're either an expert or an extrovert or both? You just call me an extrovert, silly arse. You know enough medicine, but there's no way you can know everything, no chance. This is exactly why you have to have a multidisciplinary team, both in terms of assessment and also in terms of management, both in terms of management across the medicine disciplines and in terms of management across the allied health professional disciplines, and then some, and I'll explain that in a moment. Okay, so data is always good. We have to be driven by data. This is some data from the Ehlers-Danlos Society. It established a global registry back in 2017. Just to orientate you, if you have a look there in the top right-hand corner, you'll see the numbers of individuals by diagnosis that we had in the registry in 2022, over 1,000 with HSD, over 9,000 with hypermobile EDS, just under 400 with cardiovascular, classical EDS, and 118 with vascular EDS. And the average age in the group was around 36, so we're looking at the adult population here. The distribution, male to female, 85 to 90% female. So very, very typical of our experience of EDS in our clinics and in the general population in terms of the female preponderance. Now, you'll see 4 different coloured bars. The purple represents HSD, the yellow hypermobile EDS, the blue is classical EDS, and the red is vascular EDS. And then what I've got here for you is just some of the areas that we looked at within the data, just clustered into different sets of symptoms. If I put pain in there, it would be 100%. Everybody reports pain. So the acute and chronic pain is a given. This is an acute and chronic pain disorder, or collection of disorders. But if you have a look, you can see fatigue is very highly represented across the group. And as you go down through that list, even when you get down to mast cell activation disorder, you can see that anywhere between 20 to 35% of these different groups within this population are reporting these symptoms. And that just shows you the percentages there. So this is very real data from our patients, just explaining and demonstrating the breadth of these different comorbidities and symptoms and concerns across the complexity of these conditions. We also recognise, and you'll have heard people talking about a trifecta. I think there's probably a confecta. You could go up to a septecta. It doesn't really matter where you can stop wherever you like. But you know, we do absolutely recognise that there are clusters to these things. There are patterns to these things, and it's probably because we're not looking at multiple different disorders, but we're looking at mechanisms that are triggering multiple problems within different systems. And this is just a snippet of this. This is looking at combinations of gastrointestinal disorder, pain and fatigue, allergy and inflammation, primarily in the form of mast cell activation disorder, anxiety disorders, and cardiovascular dysautonomia. Very familiar to a very large number of you, I believe. I wonder if I could just ask for a show of hands in the room for people that would say, I've got all of those. Right, and that does not surprise me at all, because if you have a look at the data, you can see that although some people with EDS or HSD will be saying, well, I don't really have those experiences, and that's important for us to recognise this isn't the same for everybody, but there are a lot of people who will say, well, you know what, I've got at least 3 of those, I've actually got all 5 of those. So this combination of complexity and the impact that it has on your health status is something that we all have to appreciate and understand, and it all has to come together in our assessment and our overall management. It's never quite that linear, of course, because we recognise that some people can have those sets of symptoms and they can be relatively mild and manageable. Some people can have all of those sorts of symptoms and they can be very, very severe, every single one of them, and very difficult to manage and chopping and changing on a day-to-day basis. We also recognise that those symptoms and concerns might kind of have equal stress and strain on your health, or there may be particular ones that are causing particular problems. Right now, with the room, the heat the way it is, as soon as you walk outside, it's probably your POTS if you've got POTS. So it varies in terms of its severity, and that's really, really important for us to also remember. It is a spectrum. It's a spectrum of presentation of the different types of problems, and it's a spectrum of the severity of those problems within each individual. That almost makes each one of you unique, but as you can see from that pattern of the data before, you do cluster together, and there probably are populations of people with HSD or hypermobile EDS who have similar patterns of disease, and we're beginning to sort of understand that and explore that a little bit more. Okay, so a question that comes up a lot is, why aren't these other comorbid conditions part of the diagnostic criteria? The first thing to say, I think, is that when the diagnostic criteria were revised in 2000, well, I'm going to say between 2015 and 17, and I'm looking at Glenda because I think you were probably part of the lead of that. So we go back to 2015, even though they were published in 2017. Although there was quite a lot of data coming through on recognising the associations with certain other conditions, there wasn't enough data to specifically say you only see it in that condition, or you see it much more in that condition than in any other condition, and actually we understand the causal relationship. So I'll explain that in a moment when you have a look at some mapping I'm going to show you of long COVID and fibromyalgia and ME/CFS, where there are very, very similar presentations with these comorbidities. So when we're thinking about is something comorbid, and there's much more data coming through, and there's more data for us to present in Toronto this September at the Scientific Symposium, we first ask ourselves the question, well, is the problem that we can see alongside the primary diagnosis of EDS had the same prevalence as it does in the general population? Let's choose, for example, type 1 diabetes. I don't think that there's any literature on type 1 diabetes being more common in EDS, but correct me if I'm wrong, but I don't think there is. But if we saw type 1 diabetes in somebody with EDS, then we would say, oh, we have a person with EDS and type 1 diabetes, because type 1 diabetes is common in the general population. We would expect to find it in some of our patients with EDS. What about then if it's a little bit more common than you see in the general population? You begin to think, okay, well, there must be an association here. Something's not quite right. However, we're seeing it in our EDS and our HSD patients, but do you see it in other patients with other conditions? And this is where the long COVID conversation comes in. This is where the fibromyalgia conversation comes in. ME/CFS conversation comes in. So yes, we do. For a number of these disorders, we do see similar kind of presentation in other diseases. So if that's the case, we can't readily say that it's a strong diagnostic marker in EDS and HSD because it doesn't differentiate you guys from somebody with long COVID, for example. However, that's really based on the strength of the evidence, and we're looking at the strength of the evidence right now as to whether there are some areas like, and I will say, for example, but I don't want you to quote me on this when we finish the revision of the criteria, cardiovascular autonomic dysfunction, some of the GI issues around mast cell activation, some of the autoinflammatory pathology that we're beginning to understand. These are likely to be much more strongly associated with EDS and HSD than we would see in other conditions, and we're starting to understand that biology. And that allows us to then actually identify whether there's a direct causal relationship. So this happens in EDS and HSD because of that mechanism, and it's a very discrete mechanism that you don't see anywhere else. And then you can say, okay, then we can be absolutely sure, like we are when there is a genetic abnormality that leads to a particular sign or pathology from the primary diagnosis, that we're actually looking at new parts of the disease that we didn't recognize or understand properly before. We're now in a much, much better space. So we're looking at the difference between association, where we can see lots and lots of people with lots of problems with their health, and it's critically important that all of those issues are understood and addressed, but they may not be diagnostic of their EDS or HSD, to causation, where we recognize how they are directly linked to your EDS or your HSD, which might then bring in some new treatments that we've not been aware of before. It might actually justify for us the empirical treatments that we've been trying to date that we borrowed, if you like, from other areas of medicine to treat the concerns that you have. I hope that makes sense, and we're working very, very hard to try and sort of tighten that up and clean that up and make it more sort of tangible for people. But the absolute take-home message I give to all of my healthcare professional colleagues is it does not mean that you ignore all of the other associations and complications that somebody's presenting with. You make a diagnosis of EDS or HSD, you then become aware from all of the other symptoms that there are all these other comorbidities, and you make those diagnoses and you treat those problems. I mentioned that we were looking outside of the immediate area. It's essential that we do because there's so much work going on all over the place. And if long COVID brought us anything good, and I'm cautious about even saying that, it's that it suddenly put in front of the rest of the world an awareness that when you have these kinds of both vaccinations and infection that drive the immune system in particular ways, you start to see pathologies that we have all recognized well before long COVID ever became something on our lips. And that is starting to help us understand that there are common inflammatory pathologies that we recognize, particularly within areas like the gut and the nervous system. We recognize the immune dysregulation that it drives. Some people have never had the comorbidities, have EDS, and then they get COVID, and suddenly all of the comorbidities appear. Some people have all of those comorbidities, they're under a reasonable amount of control, they get COVID, and everything goes crazy. And these are very real experiences. Dysautonomia, mast cell activation, changes in the microbiome, tissue damage, and also chronic fatigue. That list looks so familiar to us, but it's so familiar across the other conditions too. So this is where we get a lot of our learning. And there have been a few papers published very recently on the similarity between hypermobile EDS, HSD, and long COVID, and also the relationship between the risk of being hypermobile and developing long COVID. An area we don't yet understand, but we're getting closer to beginning to realize that this is likely to be related to autoinflammation triggered by viruses. And then that brings on the whole conversation about treatment, and it's something for us to consider when we think about resources as we go further through the course of the meeting, and we think about access. Multidisciplinary complex concerns. We recognise that you need to listen and you need to validate. We recognise that you have to do a full assessment, that you have to look at the impact on quality of life and the psychological and social well-being, treatment modalities that are likely needed across the complexity of all of this, and also supportive long-term self and medical management. So there's a lot of parallels there that we need to learn from and borrow from and bring together. Our aim then is to try and get everybody into that tick box where we know what the primary diagnosis is, we know what the secondary diagnoses are, and we have access to treatments, and that looks great. At the moment, I'm just aware of time, we are in a situation where a lot of people don't have a primary or secondary diagnosis and they don't have any treatment. Well, that's the worst of all situations, and what we want to do is, through learning like this, is get everybody into that box. Sometimes we're in a situation where we actually do have the primary diagnosis or the secondary diagnosis, and sometimes people are still not given any treatment. And I tell you the number of times I've told off colleagues and peers where they say, why do you need a diagnosis? There's no treatment. It's like, really? There's a ton of treatment and you're going to hear all about it. And sometimes we just use treatments empirically, as I've said. We don't quite understand what's going on, but we use them anyway because it feels like a safe thing to do, and what we're doing is we're moving everybody as best as we can into that tick box. Primary care, which is our first point of contact for virtually all of us if it's not the emergency room. Fabulous space, people working extremely hard, but they're doing the bulk of the work already for everything in healthcare, and as you all know, very limited resources. Go to secondary care. Secondary care, very limited in its understanding of EDS and HSD, unfortunately, very limited in its integration of chronic disease care. And in rheumatology in particular, and I'm a rheumatologist, it shames me that in the UK, and I think reflected across other parts of the world, that actually they've moved away from conditions like EDS and fibromyalgia and OA to inflammatory disorders and are not taking patients. This is a huge problem for us in terms of getting into the secondary care space, and something for us to work on. When you do get into secondary care under somebody who understands EDS, and I just flag to you that there is no such thing as an EDS specialist. We are all people that come from different walks of life that have become very familiar with EDS. It could be a cardiologist, it could be a neurosurgeon, it could be a physiotherapist, it could be a gastroenterologist, it could be a dermatologist. They are all EDS specialists in terms of their awareness. Will do all that they can to help, but they are so few in number that the resources are difficult. And getting into genetics is very, very difficult, and this is why it's pretty much gate-posted appropriately so that people understand that we're looking for the red flags that might lead to us being concerned about there being a genetic monogenic disorder, which we don't yet have as a marker for hypermobile EDS or HSD. And so when we put all of that together and we think about what we're going to talk about over the next few days, the core group that we really need to have in the middle to try and help both with advocacy and care is yourself and as the patient and the caregivers around you, your primary and your community care team, essential to this, a secondary care specialist, at least one, probably several based on your needs, and allied health professional support. And then we add to that probably a little bit of clinical psychology for some people, because this is tough. And there's a need there in terms of recognizing the mental health part of your health status as well as your physical status. We may need to bring in other experts. We may need to bring in other people supporting from allied health professions. We may need to bring in psychiatry and expertise in neurodiversity. And pretty much always we need to bring in one way or another, all those other people around us that are responsible for our well-being in terms of our psychosocial life. So I would just want to let you know that there are a huge amount of publications in different sources, different ways for you to kind of learn in this space. And we spend a lot of our time making sure that these are accessible as much as we possibly can for you. And also that there are a number of different source documents from 2017, 2021, and then coming up in 2026, a whole revision of the classification criteria and a series of update papers for you as part of the Road to 2026 work, which I've left a link there for you to have a look at as you see what we're doing over the next couple of years to bring all of these new thoughts and concepts together. Okay, I said that we would have a load of resources for you from this presentation. There are a number of videos that we put together for you from expert speakers from around the world from our ECHO series. They're there for you to have a look at. It's a rich resource. It's about 5 or 6 hours worth of material on a number of these different areas for you to explore in your resource pack. And we'll also have access to the Nutrition Summit from November last year, which was an incredibly rich source of provision about nutrition. Thank you for your attention, and I'm going to take the opportunity to go straight into our panel. I'm going to go and sit myself down, and as I sit myself down, I'm going to ask the panel from Glenda over there to just briefly introduce themselves, just by name, where you work, and your area of discipline. And we'll go straight into the panel conversation. Thank you.
Good morning, everybody. A pleasure to be here. My name is Glenda Sobey, and I lead the EDS National Diagnostic Service in the UK. Our work is based on the genetically defined types of Ehlers-Danlos syndrome, and in the other part of my professional life, I'm a dermatologist.
Hello, I'm Rebecca Ryan. I'm a gastroenterologist. Used to work in Brisbane. I'm now based on the Gold Coast, and I'm part of one of the Centre of Networks of Excellence for EDS located in Australia.
Morning everyone, I'm Nicole Frost. I'm a physiotherapist and part of the Connected Health Alliance Network of Excellence based in New South Wales, Wollongong area.
Thank you, guys.
Hi everyone, I'm Fraser Burling. I'm a rheumatologist from Auckland, New Zealand, and I have over 1,000 patients with EDS, and we are very busy.
I'm another Fraser. I'm Fraser Henderson. I'm a neurosurgeon with Metropolitan Neurosurgery Group. I'm an adjunct professor at the University of Maryland, just outside of Washington, D.C. And over the last 15 years, I think I've developed about 4,000 EDS patients.
My name is Luke Hassan. I'm a dietitian from Melbourne. I work at Active Health Clinic, and we're a clinic that works with patients with all of the invisible illnesses that Alan just went through so wonderfully. In the other part of my professional life, I work with athletes who sometimes are hypermobile and sometimes not.
Hi, all. I'm Dr. Prash Rao. I'm a neurosurgeon based in Sydney, and I don't have 4,000, but
Neither, it's okay.
but I think it's a very growing population, and very excited to be here to meet you all and learn from the experts.
Well, thank you so much to everybody for being with us. I'm going to hand that to you, Fraser, because we're going to start with thinking about cardiovascular autonomic dysfunction. And the questions that we kind of posed to ourselves were an explanation of what POTS and orthostatic intolerance really is, and how you assess it and how you treat it. Fraser.
Thank you. So orthostatic intolerance is a group of conditions, and it basically means people who are lying down feel comfortable when you stand up, your blood pressure falls into your boots for various reasons, and you feel a whole lot of symptoms. And they generally ease when you lie down again, although one or two things can persist, like brain fog and dizziness, and sometimes even the racing heart will take a while to settle down when you lie down. So why is this happening? On the left, we have a supine person where the blood is distributed normally throughout the body. And this is why when we're relaxed, lying down, we're feeling fine. When you stand up, gravity has an effect on that blood and it pulls in your legs. Now, if you're someone like me who's got normal connective tissue, it pulls a certain amount, the muscles contract, push the blood back up, and I have a function of pushing the blood back to the heart so it can pump back up to the brain again. Because our brain's actually situated up here where the gravity has caused the least blood to then reach. When you've got abnormal connective tissue, that expands more, and if you've lost exercise tolerance, which is one of the side effects as well, then you get even less effect of muscles pushing the blood back up, and it pulls in your legs, and you go faint and dizzy, your heart races and tries to compensate, and if you're really unlucky, you then faint completely. So starting with POTS, postural orthostatic tachycardia syndrome. Many of you will have heard of this condition. Many of you will have this condition. And it's a process of the heart racing when you stand up. And for adults 20 and older, it's considered a 30-beat rise, and for under 20, it's considered a 40-beat rise to reach the criteria. And the NASA-Lean test is actually probably the best test, as opposed to the tilt table test, where people can even go into cardiac arrest if they're not being monitored properly. So if you start to go faint with the NASA-Lean test, you can crumple to the ground and your blood pressure recovers. With the tilt table test, if someone doesn't lie you flat, you can end up with your brain not functioning, which is not very good. Orthostatic hypotension is where the blood's pulling in your legs, but your heart's not racing, which can sometimes be worse. And if you're really unlucky, you get both.
So, Fraser, this is where we have our first Slido question.
Okay.
This is where we test whether the Slido mechanism actually works. So, over to the tech guys. Here's your first Slido question, and it's posed to you as true or false: postural orthostatic tachycardia syndrome (POTS) can only be diagnosed with a tilt table test. True or false? Well, answer it on Slido for us. It'll come up with a lovely little bar showing what you all think.
I hope the bar's all on one side.
And if it doesn't work, we'll tell you the answer in a minute.
There we go.
Good.
Well, congratulations, audience. That's fabulous. Now, Fraser, just in terms of why it's really important that we don't rely solely on the tilt table test.
So first and foremost is the tilt table test sometimes it's reliant on the operator to pick up the symptoms and signs of the person going faint. And as I said, I've actually heard of a patient going into full cardiac arrest from not being monitored properly on a tilt table test. It's not so safe if the people don't know what they're doing. With a NASA-Lean test, is the patient's going to crumple when their blood pressure drops, and the blood pressure is then going to return back to the brain. And because the NASA-Lean test is you're actually leaning back against the wall, you're going to crumple down into a heap. You're not going to go sideways or forwards and hit your head hard.
And Fraser, just in terms of what a generalist in primary care or community care can do to still make the diagnosis without a tilt table test.
So the other advantage of the NASA test is you can actually do it at home. It's lying down for 5 to 10 minutes, stand up, have someone check your blood pressure and pulse every 30 seconds to a minute. And if you don't last 10 minutes, it doesn't matter because you know you've got a positive. If you do reach 10 minutes and your blood pulse still hasn't gone 30 points up for an adult or 40 points for a child, you know you don't have POTS. You may still have orthostatic hypotension, but you can actually diagnose this at home, and it can be done in any clinic. You don't need a tilt table, which is a very expensive piece of equipment to make the diagnosis. So anybody can make a diagnosis of POTS with a simple test.
Thank you.
So, symptoms of orthostatic intolerance. We've got lightheadedness, shortness of breath. You've got people who do faint. Now the difference, people when you do faint, some will have a little seizure, but you recover quickly within 30 seconds, as opposed to epilepsy, where you've got a post-ictal phase, which is a phase of being drowsy or unconscious, and then slurred speech, etc., for up to 15 minutes. So many people will think they've got epilepsy. It's not epilepsy. It's just seizuring with EDS, and it's a pseudo-seizure, but it is very real and is not to be ignored. Decreased concentration, less blood flow to the brain causes that. Headaches, not uncommon. Blurry vision, again, the visual centers are at the back of the brain, not enough blood flow. Fatigue and exercise intolerance, like I said before, they can actually feed back on each other. Chest discomfort, thankfully, is less common, but can still happen. You can feel the palpitations of the racing heart. At least 20% of you will feel when your heart is racing. The tremulousness or tremors, anxiety, sweating, which is the diaphoresis, and nausea, those are signs of adrenal overdrive in trying to compensate for what's happening in your body. They can happen without the adrenal overdrive, but they're a very common side effect of adrenal overdrive. So one way I like to explain this is with a tap and a glass. And you turn on the tap, put a glass under it, fill it up, empty it, fill it up, empty it again. What happens if you go faster? Less water gets in the glass. What happens if you turn the tap down? less water gets in the glass. The first one is your POTS, the second one is your orthostatic hypotension. Very simple if you think about it that way. If you've got less water getting in the glass, that's the same as less blood reaching the left ventricle. So the left ventricle's got less blood to pump around, so there's less blood pressure reaching the brain, therefore less oxygenated blood reaching the brain. You go faint, dizzy, and if you're unlucky, go splat. So the responses range from normal to full-on POTS, orthostatic hypotension, etc. Health concerns, this is not an exhaustive list, by the way. If you listen to the next session, you'll see that there's something called the surgical sieve, which shows that actually it's a whole lot more conditions as well. But these are things that we watch out for in people who have POTS or orthostatic hypotension because they all link together. Management, we start off with a non-drug company management. A glass of water, salt. How many of you here love salt? There's a reason why you love salt. Your body's craving it because it needs it to keep your blood pressure up. Salt holds fluid in the bloodstream. So the message back in the 90s and 80s about no salt in your diet, well, if you've got hypertension, you want to lower your blood pressure, reduce salt. When you've got hypotension, you want to increase the fluid in the bloodstream, and the way to do that is increase your salt. And many of you have your water bottles with electrolytes, etc. in them. Good to see. There's the stockings. Stockings aren't very fashionable. Sports tights are more fashionable, more comfortable, more easily worn. So I reckon that both of those are good measures. It's just sports tights are easy to put on as well. And they come up to the waist. And many people will have blood pooling in the abdomen also. Then we have the contributor conditions, which we saw on the last page, plus multiple others. And then we have medications. And you can have either a single therapy or a rationalized polytherapy, but I like to not have people on too many drugs because then you get side effects from the drugs. So if the non-pharmaceutical measures fail, for POTS, one of the first things to do is to slow the heart rate down with beta blockers. We've also got ivabradine, etc. We've got the volume expanders such as fludrocortisone. Some people need saline infusions on a regular basis. And then we've got the vasoconstrictors like midodrine, and we've also got desmopressin in here, which is a really important one because it's useful when you're having surgery to stop a major bleed, as noted in the 2017 documentation. So I'm going to pause there and then pass on to Rebecca and Luke because they need to be able to talk about the gastric issues, which are all closely linked together. Thank you.
Thank you very much for that. So I'm going to hand over to Rebecca. And so there's a segue here, which wouldn't necessarily be very obvious to a lot of people other than those that live with the condition. The whole relationship between POTS and mast cell activation and gut dysfunction. I think you're going to start there for us, right? And then think about fecal overloading and think about nausea as kind of really common concerns in the gut. Over to you guys.
Okay, so the way I think of POTS, MCAS and EDS, I assume that all my patients are trifecta patients, whether they have the full hypermobile EDS or whether they meet all the criteria. There are elements of the connective tissue, the aberrant mast cell degranulation and a sympathetic overdrive. But with the gut symptoms, most of the symptoms are driven by the POTS component. And I liken it to when you're running away from a lion, your gut shuts down, your anal sphincter contracts, your colon slows down, your upper gut slows down, and it's labelled as irritable bowel. But it's not irritable bowel. The trouble with the gut symptoms is that they're driven by the POTS, but then they're worsened by not recognising the POTS. And in particular, when you don't eat or drink enough salt, if you're hypovolemic, your blood is going to seek to get salt and water from wherever it can, and so it's going to pull it from the colon. So the colon's already slow, the water's getting reabsorbed and it's more constipated, but now you're under-treating your POTS because you don't know you've got it, and the hypovolemia is worsening that. When I look at the mast cell component of the gastrointestinal symptoms, we know that when mast cells degranulate, they can release substances onto nerves that cause visceral hypersensitivity. So most of the pain component of irritable bowel, the gut symptoms, is driven by the mast cells. particularly epigastric pain, but any of the pain. But it also contributes to the food allergies and the histamine intolerance, for which I send them over to Luke, which I'll give to him in a second, to discuss, because I have a lot of patients that are severely intolerant of every medication and every food, and they come to me on 3 safe foods and how do I expand that. And when I look at the connective tissue component of the gastrointestinal symptoms, that's the vascular compression syndromes, where the arteries are more lax and they can drop onto other structures, and then the pelvic floor problems. So that can make it, and so sometimes the bowel problems are because the rectum doesn't work because of an anatomical problem related to prolapse or a rectocele. And then from my point of view, if I get a patient that's extremely difficult and I'm not winning because I can't give them any drugs, then I usually send them to Luke to explore their diet to see if we can manage their symptoms through the dietary intervention, which is extremely important.
So we're going to pick up the diet side of things in a moment, but I wonder if you could just run through the anatomy of the gut. You've got some wonderful slides showing how different parts of the gut can actually be related to the MCAS and the POTS.
Yeah, so when I look at it, so dysphagia, which is the feeling of food getting stuck in your esophagus, I view eosinophilic esophagitis as the esophageal manifestation of MCAS. And in particular, when you see we treat it with a 6-food elimination diet, but dairy and wheat, when you eliminate those, account for 80%. And I believe that all trifecta patients should be given a trial at some stage of a complete dairy-free and a complete wheat-free diet, because why is just the esophagus allergic to those foods but not the rest of the gut? The rest of the gut it just mounts a mast cell response, not an eosinophil response. Whereas esophageal dysmotility from the POTS component, and the characteristic is the POTS gives you dysphagia to food and liquid, whereas the EOE is just food. So when people say, oh yeah, I'll drink a glass of water and it gets stuck, I mean, how does water get stuck in your chest? And it's just because the muscles are not. I don't actually treat that. I find that you treat the POTS, and the dysphagia from the POTS will improve as you improve that. But they do need an endoscopy. Then there's the reflux. The most common cause of reflux, traditional reflux, is an overweight person, middle-aged. The weight of their abdomen overcomes the lower esophageal sphincter. But most of my patients, when I see them, are young and thin. When you're fecally loaded, if you're full of poo, the colon will send a signal to the stomach to say, no more room down here, so stop moving. So the stomach stops moving. And in some people that mimics gastroparesis, but in other people with a lax GI junction, the acid can't go down, the acid will come up. Then there's the esophageal visceral hypersensitivity, so people that have all the symptoms of reflux, but when you give them a PPI like Nexium or Losec or something like that, it doesn't get better. And that's because it's the mast cells causing the nerves to hurt, and it mimics reflux, and that tends to respond to things like famotidine or the H2 receptor antagonists. And then there's volume reflux, which is where you bend over and stuff just comes flying up, or usually worse at night. And again, that's usually due to slowing of the GI tract from the POTS, and the food's just sitting there. And that's different to rumination. A lot of people, and completely different to vomiting. Vomiting is an active process. Rumination is another one of the Rome criteria, but rumination is literally like a cow or a ruminant. You'll eat some food, and for the first 5 to 10 minutes after eating, that food will appear back in your mouth spontaneously. It tastes yummy, just like what you ate. You can either spit it out, eat it again and swallow it, and it's not until there's been enough mixing of the contents that it comes up as acid that it self-aborts. And we treat that with diaphragmatic breathing. But I see people with bending over with volumes of fluid coming out that's acid, or vomiting digested food being mislabeled as rumination. The stomach, most common symptoms, most of the upper GI symptoms are actually coming from the colon. So the first thing I do in anyone that has upper GI symptoms is I go back to their bowel. And so people are happy with their bowels, but they're passing a hard motion every day. Well, you might be happy with your bowels, but I'm not. So any of the upper gut symptoms on their own or in combination, it's usually the fecal loading. Get the poo out, your reflux goes away. Get the poo out, your appetite returns. Get the poo out, your nausea goes. Epigastric pain here, we call it functional dyspepsia, which is extremely unhelpful. That's the mast cells. So what's making the mast cells angry? That makes them hurt your stomach. They don't like being chock full of poo. They don't like you eating things. But the most common causes, apart from fecal loading, are things that degranulate mast cells in the stomach. Stress, alcohol, non-steroidals. So people that take anti-inflammatories and get that horrible pain, that's mast cell mediated. You don't have an ulcer, but it feels like you've got an ulcer. The exaggerated gastrocolic reflex, so eat, run to the toilet. If it happens in the first 2 minutes, like first 5 minutes of eating versus the first 15 to 20 minutes after eating, that's again being chock full of poo because of the gastroileal reflex. You eat, your stomach sends a signal to the terminal ileum to move food into the bowel in preparation for food coming round. If that bowel's already chock full of poo, it's going to stretch further, release signals that go up to the stomach, release signals to the bowel to empty. But because it's so chock full of poo, it's exaggerated. 20 minutes later, the fecal loading or the full of poo is in the sigmoid colon. Postprandial epigastric pain, where it's just, or severe epigastric pain out of proportion to everything else, with or without other symptoms, makes you think of the mast cell activation, the functional dyspepsia, but also a median sort of arcuate ligament syndrome, which is driven by the connective tissue laxity. And then postprandial worsening of POTS. So before I knew about POTS, I'd have that subset of patients, irritable bowel patients, that'd say, I eat and I get brain fog and I have tachycardia and I have to go and lie down. And I'd be like, I don't know what's causing that. I can fix your gut, but I don't know what that is. And then I realised it's your eating. It's actually rapid gastric emptying. We always think POTS have slow gastric emptying, but they normally have normal gastric emptying. If it's going to be abnormal, it's actually more likely to be fast. And so they rapidly dump sugar into the small bowel. The sugar level in the blood goes up. The body says, oh, can't cope with this, can't have high blood sugar. It paralyses the stomach temporarily until the sugar level comes down. So it presents with symptoms of a slow gastric emptying, so they feel sick, they feel full, it mimics gastroparesis, but it's actually because of rapid gastric emptying. And then the high sugar causes a hormone called GIP to be released that then causes all the blood to come running into the stomach to digest the food, steals it from your brain and your heart, makes your POTS worse.
So I wonder, Rebecca, whether we could go to the first of your Slido questions, which I think is an absorption question. Do you want me to do that?
Yeah.
There's me offering. I have no idea with the technology whether I'll be able to do that. Let me just, and we're going to come back to the poo in a moment.
All about the poo.
I just can't get rid of it, can you? That's the problem. Oh, did I just go past it?
Yeah,
I went past it. I apologize.
Okay.
I'm looking for the Slido.
That one. There you go.
We go. Slido question 2. So let's put up Slido question 2, and this is really a question around small bowel and absorption.
Okay. So when would you consider a trial of digestive enzymes? And there's, does it go all the way
So
down?
this is probably mainly for the health.
Most gastroenterologists would never consider digestive enzymes because it's a herbal or it's an integrate. It's an integrative thing. We're not taught. We use Creon for pancreatic insufficiency, and other than that, we just would never use digestive enzymes. Why? By digestive enzymes, I mean ones that contain acid for the stomach, bile acid from the gallbladder, and a selection of pancreatic enzymes. So it's replacing the others. Oops. I didn't do that.
So there's a mixture of answers there. We'll come back to those, I think, in a moment. There's also going to be a question 3, which is about constipation and fibre. But I'd like to come back to question 3 because I think I need to bring in Luke. Because Luke, we've talked a lot about potential intolerances with foods. Do you want to maybe talk to your general principle slides? Shall I take you forward to those?
Yeah, sure.
Yeah,
we can do that.
And then we'll come back. Famous last words, because it's now on the Slido.
Yeah, I think we're going to have to go through the Slido.
Let's see what the Slido question says about the use of water and fibre for constipation. Okay, people like water and salt. I think you've probably got plenty to say about that.
Yeah.
If we drop that Slido down, we'll go to your principles of nutrition. There you go.
Okay. There you
If I
go.
hand that over to you.
Perfect.
And then we'll come back for the colon and the nausea conversation.
Rebecca, thank you for breaking the ice with all the poo talk. It is one of my favourite topics. I was on the aeroplane yesterday. The lady I was sitting next to saw that I was looking at the EDS HSD conference stuff. She was like, "What are you going to talk about?" And I'm like, "Mainly poo." But thank you for that overview. If I do stick to the nutritional elements, and these slides are courtesy of our Diet Nutrition Summit from November last year, and my amazing colleague Lorna Ryan, who heads up our International Consortium Diet Nutrition Working Group. Before I get to the intolerances, if I can just speak to the main things that I'm actually considering when I'm seeing a patient who is struggling with their nutrition. That might be someone that you've sent through to me, Rebecca, who has a very limited intake of food, or intake of food variety, or just someone who's seeking to get anything that they can extra, 5, 10, 15, 20% out of food to help with their condition. So I'm considering really 3 things. First is consistency, right? If you can eat 3 foods, we want to eat these 3 foods, and we want to make sure that we're trying to get as close as we can to the second point, which is getting enough energy in. If we don't sort out nutrition, energy, protein, micronutrients, the condition will likely deteriorate. Any condition will likely deteriorate, whether it's EDS, HSD, anything. The third thing is then variety. So if we can get enough and we can get it in consistently, then we can look at getting in variety. As for trying to manage intolerances and allergies, a bit of an echo. As for trying to manage those things that are limiting us in our food intake, there are many, many, many reasons why that could be happening. Rebecca's just detailed a fair few of them. So what we're trying to actually look at is where can we return to that is safe, and then how do we actually increase and elevate those foods, elevate that food intake slowly but surely over time. And people often come to me and they've been limited in their food intake for many, many years. And when we try and put food back in, sometimes what we've got to recognise is that it can take a long time as well to do that. We've got to go through this process of desensitization. Rebecca, you mentioned the mast cell, how that releases elements that create that visceral hypersensitivity. We somehow have to rework that gut to reduce how sensitive the gut is to those elements. But this slide is a really quick summary of essentially what Rebecca was talking about there. And if I think about then what we're doing to actually assess nutrition, and there's some Slido questions there we'll get to. As I said, the first thing that we're looking at is trying to get enough energy and enough protein in. We're then trying to make sure that if you've got any micronutrient deficiencies, we're actually trying to correct those, because if we think about things like iron or vitamin D or vitamin B12, they might be playing into fatigue. We might have abnormalities that are stopping us from absorbing those nutrients correctly. Then we might be looking at the quality of food. Prebiotics and probiotics are massive hot topics, and you'll notice I'm racing through this partly for time, but partly because there's so many different presentations that we can see across each of you, each and every one of you, even though I saw the majority of you put up your hand up that you like salt, which I was very, very happy about, and you've got some electrolytes in your bottles, or you're adding salt to your food over the day, which is really good. Each one of you are going to have a different set of things that you're tolerant of and things that you're not tolerant of in your diet that we really need to take into account individually and an individual perspective. There are a whole bunch of other things that, as a dietitian, I'm actually looking through. But really, if I'm thinking about some of the ways we can help with some of the things that you were talking about, Rebecca, just from a first port of call, we have to look at how we're eating our food, how we're chewing our food, how we're then swallowing our food. We're trying to look at the volume of food that we're getting in. So everyone goes, well, how can we get consistency of food if we are consistently having symptoms to that food? We've got to try and manage the volume. We've got to try and see how much you can get in before you start to experience an unreasonable level of those symptoms. We'll consider whether a fasting window might actually be appropriate for you, whether liquids are going to be a more appropriate source of nutrition for you for a period of time, which sometimes and often they are, particularly if we're managing some of those gut stasis for whatever reason type symptoms. the frequency of eating. So if we're eating less food in an actual portion of food, we need to eat more often to try and get enough food, enough energy, enough protein in. And then there's a whole bunch of other things that can actually come into play that I often defer to my wonderful medical colleagues for, around drug-nutrient interactions or drug-drug interactions, certainly the nutrient element I can speak to, what sort of doses we're having, and if there's any medical input that we can do to try and increase your food intake.
Thank you so much for that. I think we are on Slido question 6. I don't know whether we've missed one, but whether we can go to question 6. I'm looking at the tech team. Question 6 is, I ate or my patient ate a meal and had abdominal pain. This means that I should, and then there's a whole series of questions. I think this will come back to the abdominal pain conversation, which we'll bring in.
Yes, I or my patient ate a meal and had abdominal pain. This means I or they should eliminate foods in the meal from their diet. Yeah, early answers. Early answer good. This is always an interesting one with many different perspectives. You'll notice I went to the consistency and the enough element first. So if we can try and do some of the things I just talked about, and actually modify volume, modify frequency, modify how we're then going about eating and how we're actually taking it in, whether it be through changing the type, liquid, solid, or eating slower or something like that. The other thing I didn't mention, and it's along the lines of the poo conversation, is how we're actually doing the physical element of going to the toilet. So there's a sort of like squat, no, what am I talking about? There's a stool, that's the word I'm looking for. There's a stool that we can get to put our legs up on that might help with some of the anatomical complications of going to the toilet. There's actually giving ourselves enough time. It's incredible how many people are trying to live life and then running to the toilet and trying to spend as little amount of time on the toilet as possible. Sometimes we need to take a little bit more time and a little bit more care for that. And then there's a bunch of the actual dealing with some of the autonomic complications and nervous system settling strategies that we can do to try and make that bowel movement a little bit better as well.
Just with response to that question, the problem that I have is that with the abdominal pain is I see so many people on restricted diets. We need to remember that when we restrict the variety of food in our diet, we worsen the dysbiosis, or we worsen the microbiome. So instead of it being lots of good different happy bacteria, we push it towards the unhappy one, which drives the actual disease process because it worsens the leaky gut and toxins and inflammation. So even if you ate a food and you have a reaction to it, barring anaphylaxis, doesn't mean you are technically allergic, because allergic reactions are mast cell mediated. If they're IgE driven, they're IgE like a peanut allergy, but you can get the mast cells can be activated by over 300 different receptors, and if the mast cells are sensitive enough because all of the forces are aligned and you've got severe disease, anything that causes them to be activated. So you eat, and when you eat, your stomach empties, pushes foods down, stretches the colon releases serotonin in response to pressure or hard poo, and the serotonin activates the mast cells. So if you then get the poo out, I can find that you can then eat the foods. And so most of the patients that I see that ate something, gave them symptoms, took it out their diet, worsened their dysbiosis, got more constipated, ate more food, got reactions, took more things out, and so by the time they come to see me, they can have lettuce, potato and lamb and nothing else.
Yeah.
And I find that they're chock full of hard faeces, and that's what's driving it. You get the faeces out, and it can take a year and a half to get that faeces out, and as the faeces comes out, then they can eat pretty much what they want again. So the only things I would ever choose to eliminate empirically are dairy and wheat, but you've got to do it after you've got the poo out, because the poo's the driving force. So if you take the dairy out first while you're chock full of poo, you won't notice the subtle improvement from the dairy, because most of the damage is being done by the poo. So you get the poo out, then you try the dairy-free diet, then you try the wheat-free diet.
And it really does depend where they come to us on that spectrum as to where we will start with that process. So it's so important to really evaluate that before we start going about any of those empirical or otherwise restrictions, because as you've just demonstrated, it can make things a lot worse when we don't necessarily need to.
Yeah. Well, thank you very much for that. So if you're feeling sick, it's because you're constipated, okay? And if you're constipated, it's because you were feeling sick and you went down a nutritional route which these guys are telling you not to do. I'm going to move on to something neurological, but it's perhaps the wrong title in the sense that what we're looking at this stage now is the central nervous system, brain and cord, whereas we've been talking about a lot of autonomic dysfunction, a lot of gut dysfunction, inflammatory dysfunction. So with my colleagues here from the neurological side of things, just coming back to that conversation I had with you earlier, that there are many, many aspects to the neurological phenomena that we see in EDS. The Neurology Working Group of the International Consortium on EDS and HSD is actually working on on a manuscript at the moment, thinking about the EDS phenotype that is the neurology phenotype that we recognize. But we're going to focus today on craniocervical instability, atlantoaxial instability, and intracranial hypotension. And we've got Nicole with us from a physiotherapy perspective, and we have two very eminent neurosurgeons with us to think about some of the anatomical approaches and the clinical approaches to diagnosis and treatment. So the first thing I want to do is hand over to Nicole, because Nicole, we had a conversation about people being very, very familiar, if you like, with the different terminology. So what are your thoughts?
So there are a couple of related but distinct concepts that are probably important to understand to avoid confusion when we're talking around spinal instability. So first of all, hypermobility actually refers to increased physiological motion, and that's the voluntarily controlled motions that you would normally create at your joints through muscle activity. So for the neck, for example, it's flexion and extension, or looking down and up, rotation and bending to the side. Laxity, on the other hand, is referring to what we call excessive accessory motion at a joint. Now, accessory motions are normal movements, but you don't really drive them directly through your own conscious muscle activity. They occur as part of the motion, so things like the sliding of the joint surfaces or rolling, those type of spinning movements between the two joint surfaces. They're also the types of movements that might be produced by a therapist doing manual therapy at different times on the joints. If you've got increased laxity at a joint, that's sometimes confusingly then called mechanical instability, and we know that it can lead to subluxations and dislocations as well. So the term instability, by contrast, is actually a subjective experience that your joints might sublux, give way, can't be trusted. And it's ultimately due to an insufficient neuromuscular control at the joint to stabilise it. And it's sometimes called functional instability to differentiate it from that mechanical instability or laxity. So there's probably obviously a relationship between these terms. If we've got hypermobility or laxity, it could predispose somebody to developing functional instability, but it doesn't guarantee that that will happen, and they're certainly not exactly the same thing.
Thank you. And of course, this is applicable across all musculoskeletal medicine.
Yeah.
But we're now going to focus in that very, very tight and complex spot around the craniocervical junction, thinking about range of movement, excessive range of movement, laxity of the tissues and instability of the tissues and the consequences. And I want to bring in Fraser Henderson at this point because we recognise craniocervical instability at the craniocervical atlantoaxial junction. But it can come with a number of different symptoms, can't it? So we talk about the cervical-medullary syndrome. I wonder if you could maybe just explore that with us.
Thanks for differentiating between hypermobility and laxity and instability. And even in the non-EDS population, but more so in the EDS population, the joint between C1 and C2 is the most or potentially unstable in the body. And if you have instability at C1, C2, there's a very good chance that you have some degree of instability between the cranium and C1. So that's craniocervical instability. So we're going to treat them both here together because they share the same ligaments. If you have one, you may have the other. And I'll focus on three, I think, of the main symptoms. The first is the headache, which is multifactorial. But most prominent is what is occipital neuralgia, and that's pain deriving from the C2 nerve, pain along the base of the skull, the subocciput, radiating anteriorly, often to behind the orbits, behind the eyes. And I think it's often mischaracterized as a migrainous type headache. It's not migraine. But this pain is worse going over a bumpy road, worse looking side to side, and especially looking upwards. And in most patients, it's markedly improved wearing a neck brace, a stiff neck brace. So that's headaches, but there are other forms of headache as well that may complicate the condition. Now, secondly, visual changes. There may be blurred vision, double vision, or patterns, what we call tachopsia. And very often there's loss of vision for 5 seconds to even up to a minute. And I had one Mennonite patient just a few weeks ago who was 45, he had 6 children with EDS. He fixed sewing machines, and he had had these episodes of vision loss and pre-syncope, or almost fainting, for 40 years, and he thought that everyone had them. He didn't realize it was an abnormal condition, and he's scheduled for surgery. Syncope is very common, or pre-syncope, the feeling that you're going to faint if you don't immediately sit or lie down. And I'll present a couple of cases where syncope was very important. This first patient was actually, ironically, the son of my wife's sister, my nephew. And he was a strapping young man. We had no idea that he had EDS, but he had a minor procedure, after which he had symptoms of brain fog, tinnitus, ringing in the ears, visual changes, syncope, headaches, nausea, and symptoms that he described were incompatible with living. And I didn't ask him further what he meant by that. But he was turned away from a number of universities, and I told his mother to send him to me because I'm used to seeing unusual patients. Turned out he had EDS, mast cell activity, C1-2 instability, and after surgery he made an astonishing improvement and started reading prolifically and became very athletic. But let's look at the next slide. This was his CT reconstruction. That's a 3D reconstruction. And if you look at that arrow, that is the facet joint at the back of the head, where the C1 facet has rotated almost off the C2 facet. And a little bit more turning, and that could dislocate. Okay, let's look at the next case. This is a young lady from Uruguay. Her father was the archbishop there. And there were some days when she had 20 syncopal fainting episodes in one day. Severe pain, tunnel vision, tachopsia, and so on. And if you look there, her MRI showed a bending of the brainstem, and Dr. Rao will discuss some of these measurements in a few minutes. But you also see that there's a portion of the cerebellum that has sunk down through the skull base, through the foramen of Magendie, and that's called a Chiari malformation. So this constituted what we call a complex Chiari malformation, and so she needed a decompression, realignment of the skull, fusion stabilization, and she did extraordinarily well, and then went back to school and did 2 years and 1 with straight A's. So is there another slide, or we?
No, I think...
Okay, Dr. Rao, do you want to?
Prash, I wanted to ask you just really to give us a sort of a brief summary of the imaging modalities that are sort of available to help facilitate understanding what's happening anatomically.
Thanks, Dr. Hakim and Dr. Henderson. So I got introduced to this by Dr. Henderson, seeing a patient of mine from Sydney, actually from Brisbane. So we all talked about the instability and how you got to diagnose it. How many of you have been told that all your imaging are normal? there's nothing wrong on your scan. It looks better than what your age looks. So it's a very common way to say it, right? In fact, if I see any patient on a physical basis or a structural basis on a scan, EDS patients look much younger than the normal people. That doesn't mean it's normal. So we've looked at a number of ways of measuring. When you look at a supine scan, everything looks normal because it's all aligned most of the times. So we've looked at functional imaging such as upright MRI, which unfortunately we've got decommissioned in Sydney. But if you see those scans, you can start to see with dynamic imaging such as flexion, extension, rotation, even within the limitations of what the scanner can actually do. If you look at, I used to measure this as a part of a study just around COVID. When you look at the measurements between C1 and C2, there's such an enormous exaggerated motion that you can never measure on an upright MRI or anywhere because you just have such a confined space, and the radiographers will actually tell you do not turn too much. So we have looked at, in this paper, the various different measurements, the bending of the brainstem cervical spine region with the basion and the C2. I then look at the retroodontoid space that's probably compressing the spinal cord in different angles. And also look at rotational of the C1 and C2. And to me, that's a very important thing that, if your rotation is above 40 plus, then it's much more than what I see in a normal patient. There was a paper from White and Punjabi, I think in 1960s, there's a rotation more than 41 degrees was associated with vertebral artery compression. And then you're looking at subluxations that, again, a dynamic imaging will show a C1-2 subluxation. So looking at all of these, I tend to at least say 2 out of the 5, if they're abnormal, they have some degree of craniocervical, whether you say abnormality or instability, because we've all been taught about instability being a traumatic injury. So we don't have any measurements for EDS versus non-EDS.
Thank you very much. And I've just gone through some of those rotational images, CT images, and some of the upright MRI dynamic images where you can see the pathology, the changes as a consequence of actually looking at anatomical function. I'm going to come over now to Nicole to talk about the kind of conservative treatment, if you like, the principles. So over to you. I think you have a couple of slides.
I think the animations have actually not worked anyway, all there. But
okay.
So just remembering back to the definitions before, and we're talking about functional instability being defined as the feeling the joints can't be trusted due to insufficient neuromuscular control. So we know that we definitely see a pattern where there is hypermobility or laxity, an increased likelihood of developing functional instability, but not an inevitability. So it's like it's a risk factor for this to develop when it's combined with a reduction in muscle function, so that muscle function becomes inadequate to control that joint range. But yes, someone who has inherently stiffer joints or tighter connective tissue may get a similar reduction in muscle function and not develop functional instability as a result. So we know we've got many hypermobile individuals out there who are experiencing various degrees of functional instability, but likewise we've also got extremely hypermobile individuals with absolutely zero signs of cervical instability. So there doesn't seem to be that direct relationship between the laxity or hypermobility and the symptoms that are experienced, that degree of functional instability. So that sort of really brings us to focus on the point of difference in these people being that neuromuscular control. That's the major difference between whether or not the person is symptomatic of having instability. So we can have that hypermobile but stable and happy neck versus a very unhappy, unstable, hypermobile neck. So I think we've gone. So if we're talking about there being inadequate muscular control to stabilise the joints, then that's really our focus, is to try and balance that out, to have enough muscle control to meet the demands on the joints. So there's two basic pathways that we can use to achieve that, and I'll probably try and whip through this fairly quickly because I know we're running short on time. But the two obvious things are we can either increase muscle control or we can reduce the demands on the system. And in reality, we're going to try and do a bit of both. So working on training the muscular system as part of conservative management, we're trying to achieve a muscle system that can efficiently control the joints. It needs to turn the right muscle on at the right time, and it needs to have enough strength and endurance to do that for as long as the job required of it demands it. In addition, for the muscles to be able to efficiently control the joints, they also require sensory information about what's happening in the neck. You can't control something if you don't actually know where it is in space. So effective treatment will often require training of sensory functions, and lots of you have probably heard about the reduced proprioception in our hypermobiles, and that's the sense of where our body parts are in space, and commonly not that great. And we need to be able to integrate that proprioceptive information with information coming from the visual and the vestibular systems in order to get the muscle control working well. In parallel to that, there's a whole range of things we can look at to reduce the demands on the system, which you can see there. So we're going to be looking at ergonomics, external supports like collars and use of furniture, pacing strategies so that we can try and give those neck muscles a rest before they hit complete overload and trigger spirals of further dysfunction. Breathing training can be really critical. If we've got aberrant breathing patterns, often they're putting a lot of extra demand on the neck, and if we can reset that, there's a demand that we can reduce. Working on the alignment and control of the entire body is essential. We can't look at the neck just in isolation. And then pain management strategies are important, not just because the pain in and of itself is an unpleasant experience, but it's important to understand that pain actually impacts the muscle function. So we have patterns whereby ongoing pain actually makes some of the deep joint stabilising muscles less active, it inhibits them, while winding up the activity in some of the large superficial muscles into sort of a splinting or guarding kind of action. An important point that often comes up with quite polarised views here is whether or not manual therapy should be part of managing hypermobile or unstable necks. And I think the answer is actually far more nuanced than an absolute yes or no. It can be an absolutely important part of treatment in these conditions as long as it's used appropriately. So it can be very helpfully used to improve that body alignment and to get the neck balanced more over the base of support, to reduce the pain, helping to reset that muscle function, getting the deep stabilisers more activated, and the big global splinting muscles to actually wind down and reduce that activity. But it does need to be delivered appropriately in the context of the patient's presentation, and it may be quite different to the way manual therapy would actually be delivered for a non-hypermobile or unstable neck. Okay. So just coming back to talking about postural effects and that alignment of head over the body, there's some studies sort of modelling the forces through the neck in different head positions, and they've shown that particularly that forward head position that we commonly see compared to a neutral posture actually magnifies the effective weight of the head by up to 5-fold. So Sung and colleagues reviewed the effect of this further, and if we can bring that up. They noted some research that shows that in the neutral head position, the muscles at the base of the skull attaching the neck and skull will be contracting at something like about 10 to 18% of their capacity. And at that rate, they can maintain that for a duration of 4 to 8 hours on average. By comparison, in the forward head posture, the muscles are then going to be working at up to about 40% of their capacity, and that brings them to fatigue in a matter of a couple of minutes. So if we're aiming to match that muscle capacity to demand, trying to reduce that head forward posture and get the head in a more aligned, balanced position over the body can have a huge effect.
Thank you. I think that brings in Slido question 8, which is all about hypermobility. So true or false on your Slido question. In hypermobility, headache plus neck pain must mean that you have cervical instability. True or false? Thankfully, yes. And because so much of the work that we do is a combination of all of the different facets that you've been discussing. I'm very aware of time. What I'd like to do is I'd like to just bring in that there are very specific indications for surgery. And I wonder if I could just ask, can we have our Slido down and our slide deck back. Tech people, please, thank you. I should know a name. Calling you tech people is really rude. John, I'll call you John. Surgical treatment.
Do you want Fraser 1 or Fraser 2?
Fraser 1, Fraser 2. Fraser 1.
Okay. Right, for surgery, you need someone who has really ruled out all of the non-operative treatments that, patient who's tried them, who's worn the neck brace, done her isometric exercises, and done a very good course of physical therapy. A patient who still has a headache of about 7/10 or worse, and many of the symptoms of the cervical medullary syndrome, which we discussed, the headache, nausea, brain fog, dysautonomia, weakness, sensory loss, visual changes, sometimes auditory changes, tinnitus. They're the symptoms of the cervical medullary syndrome, and they are referable to the upper spinal cord and lower brainstem, and include dysphagia, choking, sleep apnea as well. Thirdly, there should be congruent neurologic deficits. If someone's completely neurologically intact, then it's unlikely that they will need surgery. But usually there's weakness, hyperreflexia, spastic reflexes. There may be some incoordination, and very commonly significant sensory deficits to pinprick. You might feel the pinprick, but it's not painful. And finally, there should be congruent radiological findings. Dr. Rao outlined a number of the measurements, and you should be able to measure the instability using dynamic imaging. That's the flexion extension MRI and the rotational CT scan. And then in the more severe cases, you can see instability on a supine MRI, but usually you're going to need dynamic imaging to demonstrate the ligamentous laxity.
Thank you very much. And your outcomes from surgery, really incredible in terms of the control of people's symptoms.
I think Dr. Rao would probably agree that if you pick the patient carefully and do a good surgery, the results are very, very good. And you can see from our last publication of 53 patients that we published, I think earlier last year, we saw highly statistically significant improvement in neck pain, headaches, vertigo, brain fog, numbness and weakness, syncope, palpitations, dizziness, tremors, nausea, exercise intolerance, anxiety, depression, and actually fatigue. We saw improvement in fatigue as well.
Amazing. So I'm going to finish the neurosurgical conversation here. There is a lot more that we could be talking about, but I can see that our people who are controlling the timing are probably having a nervous breakdown now. But I do not want to eat too much into the Q&A, but I do want to give time to skin. So I'm going to hand over to you for a discussion about the common skin findings and some of the common questions that you experience. Actually, it was unfair of me to do that because I actually need to get you to the right place. You'd think I'd know what I'm doing, but I'm blagging it as I go. There we go. And we will talk about some more of this throughout. Here we go, skin. Glenda.
Thank you. So the skin is the largest organ in the body. And I think you'll have to agree with me, that means unquestionably that dermatologists are the most important doctors. We always just like to get that clear. So, as such, there are many diseases and conditions of the skin, ranging from inflammatory conditions through to tumors of the skin. And most people, during a course of their lifetime, will experience several different types of skin disorder. But really what I'm going to talk about today is the work that is specifically done in my service, where we look at the skin in the genetically defined types of EDS. Now, these days, when we're wanting to look at this group of conditions, we are able to request a panel of genetic tests. Back in the old days, and I don't wish to age myself too much through this, we would see a patient, examine them, look at the clinical signs, and we could then, if we thought it was pertinent, and I see Dr. Francomano smiling at me, she's been in the same position, we could request a single genetic test based on what we thought was the most likely diagnosis. At that time in the UK, a single genetic test cost about £1,000. So you might imagine that our administrators really liked us to get it right first time. This meant that we looked at the skin in great detail, and our patients were often a little surprised when they came to see us, and after we'd taken the history, we'd get them to get undressed, put on one of our glamorous hospital robes, and then have a very good look at all of their skin, hoping to find clues there towards making the right clinical diagnosis. Skin hyperextensibility is common in the rare types of Ehlers-Danlos syndrome, in some particular types. And I think the thing to say about skin hyperextensibility in the genetically defined types of Ehlers-Danlos syndrome is, as you can see in these pictures here, quite significant. When I give talks to colleagues and I look out over the audience and I'm talking about skin hyperextensibility, I see them surreptitiously checking the back of their hand just to see how stretchy their skin is. In the genetically defined types where this is a feature, there's really no doubt about it. The skin is significantly hyperextensible, and it's hyperextensible at many different sites on the body, not just at one or two sites. So a number of us, shall we say over the age of 27 in my department, decided to go into the ladies' room and stand in front of the mirror and stretch the skin on the side of the neck. I really warn against this in general because most people over a certain age, especially if they've had a bit of sun exposure, can get quite a fair bit of traction on the neck. In the genetically defined types, we're looking at seeing this at a variety of different sites. The elbows and the knees are quite a good place to start, and that's something where people don't feel too exposed by you doing it. But certainly in some of our patients most significantly affected with a classical type of Ehlers-Danlos syndrome, you can actually lift the skin of the scalp away, just to give an idea of the extent of skin hyperextensibility that's possible. When we look at scarring and bruising, bruising is really difficult. I mention it under skin because it's where you see the bruising most easily, but of course bruising is related to a whole host of other issues, including hematological issues, and indeed in people who have difficulty with proprioception and are hypermobile, they are much more likely to be bruised by injury, really, than anything else. The scarring that we see in the genetically defined types can be extremely extensive. Particularly the shins is a good place to look for the scarring, and we see that the scarring will be retained. In the early days and sometimes even early years, we'll see a purplish tone or even a brown tone from hemosiderin. That's when there's been bruising associated with the injury. Dermatologists who do skin checks on people become familiar with what is normal scarring. So normal scarring from ordinary injuries, normal scarring from surgeries, and it depends exactly on the surgery and the site of the surgery. So for instance, surgery over a knee joint is likely to have much more significant scarring than surgery, say, on the forearm. It also depends how carefully you've been sewn up. So some degree of scarring can just be part of normal life. Skin splitting is something that we ask very particularly about in the very detailed history we take from our EDS patients. And skin splitting is an unusual phenomenon that we see almost exclusively in our classical Ehlers-Danlos syndrome patients. And it is something that is extremely alarming to see. I like to think at this stage in my career that I'm not too easily alarmed, but when parents show me photographs of their children who have had a bump against the side of the table and their skin has split open, I chose a very minor manifestation of it to show here because of how alarming and upsetting it can be to see. But in the case of one little boy, a bump on his shoulder and his skin split all the way down to his elbow. So in these individuals, and particularly in childhood, where bumps and knocks are more common, we need to think really carefully about protecting the skin from injury. In these days where athleisure clothing is more accessible and people can readily get compression clothing that's used as it is fashionably by athletes, we find that children are much more keen to be covered up in things that look good. In the old days, we were getting our occupational therapists to measure and fit garments for this group of children, which they never really liked the looking of, and it was quite a negotiation to get them to wear it. But you can imagine that in the situation of skin splitting, how important that is, that the skin is protected in the first instance. So what are the special considerations for skin in this group of individuals? Well, day-to-day care of the skin is, of course, important, as it is for all of us, and this includes sun protection. Because when we look at biopsies of skin that is not photoprotected, we see that, honestly, the sun fries collagen. If you have issues with collagen genes, the last thing you want to do is put your collagen at an additional disadvantage. I've spoken already about protecting the skin against injury, and that when injury results in a wound, special care is needed in management where necessary, and that's for a wound of any significant size. We do prefer suturing to be done in layers, and for the area involved to have additional protection. If our patients with the genetically defined types need to have elective surgery, we like to have a multidisciplinary team meeting together with the surgeon to find out exactly what the surgery will entail, and then give our perspective on the type of EDS that the individual has. And while it's always inadvisable to tell a surgeon what to do, just to try to balance the expectations on both sides. I was taught very early on in my medical career that time and trouble taken early on saves a lot for later, and this is very much the case of what we find by having these multidisciplinary meetings. And that's everything from me.
Thank you. That's wonderful. Thank you very much to all of the panel. So I'm going to ask John to reset the timer for me. I'm thinking we've got about 15 minutes to try and keep on track here. And I've been looking through the Slido questions that you've all been submitting, and they've only given me 3 minutes. Now we're in trouble. Guys, there are 59 questions here, so we're not going to go through them all. But what I'm going to ask you is, if I was to send you some of the questions, would you mind just having a look at those and responding to them in Slido, because then everybody can see the responses. But there have been a few questions that have come up about the NASA test, and just asking what it actually is. I wonder if you could just describe it to us as the alternative to the tilt table test.
So I'm going to stand over here. You actually have your feet about a foot forward, leaning back against a wall. And that's not going to hold me up, but anyway, that's approximately what's happening. So
for you.
You start off with a lying flat, then you stand up, and the reason why it's called a slump test, because if you go faint and dizzy, you can just slump to the floor. Okay? So it's very easy to slump rather than falling forwards, going splat, or falling to the side, because it's so you're actually not going to be in an unsafe position. Some people will have a little extra mat on the floor to do it, just in case you do lose consciousness. But you're measuring the pulse and blood pressure when lying down, and then you're repeating the pulse and blood pressure when you're standing up. And that just makes it a whole lot easier, because if your pulse goes immediately through the roof, you're going to notice it very quickly, very easily. Some people have a slower rise in pulse, and it gets worse the longer you're standing up. Others have it rise quickly and then come back down. If it's not sustained up there, that's actually a negative test. So it needs to go up and stay up. One of our favourite cardiologists in Auckland, Fiona Stewart, she notes that if it's positive by 5 minutes, it's going to be positive at 10 minutes, and so she'll often stop at 5 minutes. So some people don't have to go to 10 minutes. If it's a little bit borderline, you might go a little bit further with it and make sure you do the full 10 minutes. But it's actually a very good test and a good distinguisher, so a high positive predictive value of determining whether someone's got POTS or not.
Thank you very much.
One thing I will add to that is I ask my patients to do it 3 times. I ask my patients to do it 3 times, and you do it in the morning, because POTS is worse in the morning. So you'll get a positive test in the morning, but if you repeat it in the afternoon, you may get a negative test. And I find that if they do it 3 times in the morning, that's usually enough to catch it. But you'll see orthostatic hypertension on one test, the next test is normal, and then the next test is POTS. So, and if you go to the Bateman Centre, online there are, I think they're an MES CFS centre in America, there's an actual sheet and diagram, and they've showed pictures of how to stand and step by step on how to actually do the test. So,
Thank you. I'm going to ask this next question to Rebecca and to Luke, and it's around dumping syndrome in the presence of gastroparesis, and how much you see that as an issue, and the cycling that can happen.
The problem is I don't believe in gastroparesis in this subgroup of patients. Gastroparesis, where paralysis of the stomach muscles. The muscles aren't paralysed, they've temporarily stopped working in response to something else. And the same with the dumping syndromes. I find the dumping syndromes are the gastrointestinal symptoms of the POTS manifestations of the gut, combined with the unusual form of diabetes that the patients get. And when you understand those two, I no longer believe in gastroparesis or dumping in this subgroup. So if you give me a set of symptoms, I can sort of set it out. But like with the, if you have postprandial diarrhoea, so like I said before, it's related to where the loading is, so where you eat and then instantly have diarrhoea. There's no way you can eat and have the food come out within 20 minutes. It just doesn't go that fast. So it looks like it's coming out with what you've eaten, but it's not. It's older food. And then there's the postprandial hyperglycemia, and then there's the reactive hypo. And that's related to rapid emptying, high sugar, and then you overshoot with the insulin, and then up to 4 hours later you'll have a hypoglycemic event. And so I call it dysautonomic diabetes. With blood sugar controls, there's an article that just came out recently in our group about the reactive hypos in the EDS population. But anyone that has autonomic dysfunction or MCAS, I see the postprandial hyperglycemia, fasting hypos, reactive hypos, and nocturnal hypos.
And how do you handle that from advice in the nutrition side of things?
Practically, it can get quite complicated because we, of course, want to manage the blood sugar as best we can, but to manage the practical symptom element and to get enough nutrition in, often we have to go for a source of liquid nutrition intertwined with solids, maybe not, but often the liquid nutrition can be something that increases that blood sugar spike as well. So trying to manage that and get that right is difficult. Sometimes we get a continuous glucose monitor and actually look at what's going on when we have certain foods there. But really, as I said, the primary thing that I'm worried about is getting people enough nutrition in, and we'll do that however we can and work with people like Rebecca and others to manage the complications of that with medicine and otherwise.
Thank you so much. So there are a number of other questions here. It looks like it's probably going to be about nutrition and also about POTS. So you guys hang back and I will keep you busy. But I want to take this opportunity to thank the whole of the panel for an amazing session, to thank you all for your time. I apologise to John and everybody else who's been tracking the time, and I've been failing miserably throughout the whole thing, but you couldn't tell, right? So thank you very much. This is the end of this session, and I think that you're going to go to a wiggle break now, but I'm going to let Lara do the introductions and ask the panel if we would just clear the stage. Thank you.